common questions that we get around the Eclipse and Aurora grafts have to do with the rate of breakdown, also how to optimize outcomes and how to sort of optimize the patient experience and really safeguard good outcomes. In short, the rate of breakdown and absorption is roughly proportional to the surface area of compromised epithelium. So the greater the degree of epithelial compromise, the quicker the rate of breakdown, the quicker the absorption. It's not impossible that if you have somebody with diffuse epithelial loss, they'll come back, let's say, the next day after placement, and the membrane's broken down and absorbed in that time. The other side of that would be you have somebody with a tiny 1x1 defect. You cover, the entire cornea with a 12-millimeter graft. They come back a few days later, and much of the graft is intact because there's just a tiny area of compromised epithelium where you're going to have the quickest breakdown, and it'll be a bit slower everywhere else. The graft also tends to adhere best over areas of compromised epithelium. That's why sometimes you have folks who have or who say they take, let's say, a Wexel or a rounded ophthalmic sponge and tend to dry the cornea before they apply the graft. What they're doing is really creating microepithelial defects that'll optimize adherence. It's partly drying, but it's large. You can just keep the eye open with a speculum or with finger-made speculum there, which will allow the ocular surface to dry really well. And if it's dry long enough, if it's dry for long enough, you'll get microepithelial defects, which will also optimize adherence. But to speed that up a bit, you can use a Wexel to sort of dry the cornea, in the process creating microepithelial defects, which will optimize adherence. A bandage contact lens is certainly part of the treatment process, and there are two concerns with sleeping with a contact lens, and they're really around oxygen and infection. You want to try and choose a bandage contact lens that allows maximal oxygen flow to the cornea, high DK value lens. And as far as infection goes, we typically will use an eye drop during treatment that contains an antibiotic, a minimally viscous eye drop, something like Tobradex or Maxitrol, that contains antibiotics that are known to be effective on the ocular surface for keeping the proliferation of most of the common bacterial offenders on the ocular surface in check. So Tobradex is great, Maxitrol is great as well. Tobradex ST works really well as well. Other products that might be a bit more viscous, we tend not to use. Now, you notice I'm mentioning products that contain an antibiotic and also a steroid. Unless the patient is acutely post-herpetic, I'm going to tend to want to use something that's got a combination antibiotic steroid. Why? Because like we said, oxygen and infection are your two concerns when sleeping with a contact lens. And if you've ever seen a hypoxic keratitis, someone who slept with a contact lens, or maybe you've done an amniotic graft with a bandage lens on it, you didn't give them lubricant drops, didn't send them out with a combination antibiotic steroid drop, and they came back a day or two later uncomfortable with corneal edema and also a hypoxic infiltrate, maybe even a hypoxic ulcer. You can effectively and safely offset all that hypoxic sequelae, safeguarding your outcome and optimizing the patient experience by using a combination antibiotic steroid drop. The steroid component will help keep the hypoxic sequelae in check for the duration of treatment, which is typically between 2 to 7 days. And then the antibiotic component will help keep the proliferation of most of the common bacterial offenders on the ocular surface also in check for the duration of treatment. I also like to give a non-preserved lubricant drop, not minimally viscous lubricant drop, like a non-preserved artificial tear, multiple times a day, maybe every 4 to 6 hours while awake for the duration of treatment. Again, allowing the exchange of fluid and oxygen underneath the contact lens, further offsetting the risk of hypoxic sequelae. Plus, the cells that are going to heal the different parts of the cornea, they're really going to come from the peripheral aspects of the cornea, from the limbus, that kind of migrate towards the defect, and they do so more effectively on a wet surface than a dry surface. So again, there's a good tidbit about the benefit of adding a lubricant drop. Aside from that, these are very safe products to use. They're very effective products to use. They're very comfortable for the patients to use. My personal go-to now has become the Aurora graft that has that 5-millimeter central aperture that allows the patient to have essentially no visual disruption for the duration of treatment. The less disruptive the first eye is, the more happy they are to do the second eye. Aside from that, guys, when you think of hypoxic sequelae, you're not going to have any central hypoxic sequelae within that pupillary zone if you didn't cover it in the first place. So that's in the case of a monocular patient or a patient who's got, let's say, one amblyopic eye, and you're treating a good eye, and the defect is not central. Aurora is a great graft for that purpose. Again, safeguarding the patient and provider from any untoward scenarios. Any questions, please feel free to reach out to Ophthalogix or to me. They can put you in contact with me as well. Happy to answer any questions. Good luck and good cases.